Okay, we're going to give it a couple more minutes to let everyone connect.
Here?
No.
For you. Oh, it's for you. Okay. Oh.
Okay, everyone, let's get started. As you probably are no doubt aware, we have a lot to go through. And so first, appreciate everyone taking the time for the meeting today. I know this is kind of a lunch hour for most people, and also appreciate going through the pre-reads that we sent beforehand. Once again, in terms of our role, we're really process support and decision support for the panel, as the panel kind of thinks through health and education and thinking about prioritization and what areas to focus on for sending recommendations to the SPARC Executive Committee. And so with that context, we took some of the steers that we heard from the panel in the last session and brought in kind of new sets of information. And as you'll see as we get into it, for during the discussion, some experts to talk about some of the areas as we go through. The goal for today is to spend most of the time, and we're really just focusing on this session. We had decided with the panel chairs to split the sessions into two, one for healthcare and one for education, just because of the breadth of topics to be covered in each one. Didn't feel like we'd be able to do either justice. If we tried to put them together at this point. So we're going to have a meeting 3A and a meeting 3B. Then for meeting 4, once we've defined kind of the programmatic areas of highest focus to look at and to flesh out for solutions around those, then to go through the scoring exercise in an integrated fashion. But didn't think we were really going to be able to get through kind of the bulk of these detailed discussions today, trying to do it all together. So once again, it is a health focus today. Go on to the next slide, but just so where people know where we are in the filtering process. Once again, we're at the point where, we have a tremendous amount of information and a tremendous amount of submissions, and really need to start talking through it, and the panel needs to start focusing in a little bit, even in anticipation of the scoring exercise, where we can understand how the kind of programmatic areas that it develops stand against each other as well, in anticipation of putting together that final recommendation set. On the next slide, really lays out at a macro level, the need for focus. And so now that, we've had all the submissions are in, we've had a chance to kind of look at them, sort them in a bunch of different factors, and step back, we understand kind of the magnitude of the challenge here. In that, if you look at the total funding requests in the submissions, and the submissions may not actually encompass everything that, the panels put forward, because as each panel goes through the areas of need and maybe the highest catalytic leverage points, it may come up with some other areas based on things other states are doing, for instance. But even just that alone from the submissions, which ranged from pure ideas to things that were more specific projects, that's almost $13 billion. In health education alone, it was $2.8 billion, and that's against a total available spend of SPARC funds at this point of $721 million. So definitely going to need some prioritization in order to really focus in on those key areas of need and opportunity that can really be catalytic per the request of the Spark Executive Committee, around Kansas's future. And it also points to the fact that, and it may not be quite as big in area here as it could be in some of the other panels, but really identify co-investment opportunities to continue to leverage these funds. So if something's a local opportunity, looking for opportunities to have, for instance, state, local funding on any of these, just so we make sure that the dollars go farther as appropriate. In slide 4, I think I mentioned this before, we broke up the third meeting across the 5, into the 2 sessions. And so we're going to spend a lot of time today going through in detail the healthcare areas, which we've done some filtering and profiling based on what we heard from the panel members last time. It would be great to, it'd be great to be able to see how these things stack up against these other sources of information and sorting them around other pieces of data. The other thing to keep in mind as we kind of look at this kind of integrated set of meetings is the fact that the good news is we're only halfway through. And, we've gotten to the point where, where we should all feel pretty good that we're bringing to bear a lot of the information, both in terms of the submissions and needs and understanding how all of this lays out within the context of other sources of funding and recommendations and expertise of other organizations. So we're kind of really poised at that point to begin to be able to focus in and dive in and continue to make sure that in the areas the panel wants to focus on, they can craft the best kind of solution areas to really focus in on. So right now in this session, like I said, this is the last of these kind of third meetings that we're having across the panels. It really is kind of a tipping point, and it's a lot of information coming in, coming out of it with some greater focus and clarity would be really beneficial. And we've managed to achieve that in the other 3 panels at this point. So may have been a little bit of a messy process, but we've achieved it. On the next slide, just to clarify, and I'm going through these pretty fast because I want to make sure we get into the bulk of the discussion around the issues. But this just points out what we had talked about last time, which was when we looked at all of the submissions that came in, and across the areas, from early childhood development, K-12 higher ed to behavioral health, all the way through to senior services. And then, you looked at kind of which kind of areas of needs, all the way from basic needs to capacity building to other enablers, where they fell. The submissions fell across, almost every single one of those cells. Once again, we're really focusing on the things on the right-hand side there that have been highlighted. And even within those, once again, our goal is to say, which of those cells do we think are going to be the most important cells to really focus in on to try and drive some solutions? One thing we may not get to today probably, but we'll probably have some time at the end of the education meeting on 3B, is to then be able to say, now, are there some rows like workforce, recruiting and retaining incentives or pipeline development that at least within healthcare, there may be some kind of common platform solutions that we could consider, right? We could start building it out in one area, but it may have a little bit more juice than in one particular focus area. Slide 6 really kind of talks about how to think about what we're trying to accomplish. And we've been using the term kind of programmatic areas. And we talked about that a little bit last time, where we showed our process starting from the left around needs, focus areas, identifying needs, and then on the right, looking at the submissions and honing in on programmatic areas, could be called strategic areas of focus, but it's like really where are the places where we think the greatest needs are and the greatest opportunities for solutions are for this set of funds. And highlight those that we really want to be able to kind of look at and provide recommendations around. Now, submissions specific submissions will fall into those areas, and we're going to need those in order to identify kind of what the funding envelope is for the high priority areas that get passed up to the Spark Executive Committee. The one thing is being able to, do a final approval of a project. It won't be able to happen at the advisory panel level first, because the Spark Executive Committee still needs to be able to look across everything that's coming to it and need to make some trade-offs. Then it needs to go to the Finance Council. And then even after that, there are some requirements from a Treasury perspective around procurement. But that being said, if the programmatic area gets focused on and approved, those submissions will still reside within the context of those areas that have been approved and as we move forward. But that is just kind of from a terminology standpoint, wanted to put that out there to kind of clarify for some folks. I'm not going to try and go too much on the next slide, slide 7, because I think we've largely talked about those pieces. So slide 8, we're going to now start getting into the review. Looks like I'm 5 minutes ahead, which is good because we have a lot of stuff that we need to go through. In terms of, just really quickly as we go into how we're going to look at each one of these areas, we talked a little bit last time around how to think about filtering, and certainly around allowability, and are there other sources of funds? Is this an investment type that's one time or ongoing? What's the evidence of need? And then finally, there are some specific areas that were important to this panel that we picked up. And one was around, is this impact, geographically distributed? Where we'd heard from some folks saying it's not going to be the be all and end all, but understanding, what are kind of systemic solutions that could raise a lot of boats versus things that are point solutions. We should understand the difference of those. Once again, not a hard filter area, but something we should understand. But I think part of the implication of that is, if something is a systemic solution, it may get looked at a little differently, which links into, is it a broad solution or not? There are some point solutions that are super important to address, but we'll just need to understand that across these. So slide 10, and I'm not going to try and go through it, but there is a tremendous amount of pre-reads that went out, and we're going to be referencing some of those slides as we go through. But what was in those pre-reads was really the attempt to respond to the panel and show kind of all the other sources of information that could be brought to bear for the request of the panel, to think about each one of these areas. And like I said as well, we brought some expert voices in here as well around the topics that we're going to be covering. And then this slide, and then I'll open up for discussion again on the next slide before we jump into some more stuff, is just as we remind ourselves every time, the guiding principles that the Spark Executive Committee put forward should be top of mind, because they're going to be certainly thinking through this lens when they see what's being recommended and deciding which areas to go forward or not. Prioritize sustainable programs and investments through one-time use of funds. Combine with leverage local and other agency funds to maximize use of discretionary funds. And also we should make sure we're thinking, okay, are there areas that haven't received much funding, an important area of need, versus there may be some that have received a lot of funding, not that needs still don't exist, but we should be aware of how much funding the various areas have received. Do things that foster long-term systemic impact for Kansas. So that, I think, leads a little bit into the direction we got last time around identify if something's kind of a systemic solution versus a point solution. Consider equitable opportunities and outcomes, and we do have the ability to filter to understand which submissions, for instance, are how they distribute across geography across Kansas. And then even as we think about things at a program level, we have kind of specific things, but also just enabling some flexibility with strategies. And then finally, which is true for this process as well as for each one of the recommendation areas, in implementation, make sure that we can measure the results, track them, and we're transparent around where the progress is. So, and once again, I promise I'll stop talking after I intro the slide and let people kind of chime in before we dive into all the specific areas. But I've alluded to a lot of this, but what we heard in meeting 2 was investment should build on proven interventions and expert recommendations. Kind of a real goal to, hey, let's bring in some expertise to think about all of this. And also focusing in on some areas will allow us to continue to do that more rather than trying to get expertise in every area. Investment should be made in areas that have largely allowable programs or existing funding is insufficient or limited. Investment should support statewide long-term transformation, and we should avoid establishing programs requiring ongoing funding. So hopefully those were things that the panel felt were pretty important. We thought we heard that because we've actually portrayed these areas and the submissions in the context of those things. But I guess I'll stop talking there and ask, are there any additional principles the panel should consider? Or did we hear some of these things wrong?
I think it looks like you're right on track.
Okay, great. Hey, and by the way, I realized I was kind of negligent, and I never even gave Senator Erickson or Robin the chance to say anything kind of at the start of this. So my apologies for that. There's just so much material. I wanted to start getting to the meat of it. But anyway, before we dive into the meat right now, I'd open it up and say, Robin or Senator Erickson, if you have any kind of thoughts or advice for us going into this, feel free to kind of let everyone know at this point.
Thank you, John. I appreciate having some experts with us today to help us wade through this. I appreciate the opportunity, but I'm ready to just keep keeping on with the agenda.
Okay, great. Great. Awesome. Well, let's keep going. And now this will be less of me talking and more getting into each one of the areas. Go to slide 14. We have been lucky enough to have some experts agree to be part of the process now. They have expertise in some across most of the areas, some in much more focused in specific areas. But I would just ask, David, Carrie, Hina, and Mike, why don't you first, thank you very much for taking the time, really appreciate it. And secondly, if you could just kind of give some quick introductions and to the panel. David, are you here? David was potentially going to need to be a little bit late to the party here for this. How about Carrie?
Hi, thank you. I'm Carrie Bruffett. I'm the Vice President for Policy at the Kansas Health Institute. I've been at KHI a little over 6 years. Before that, I was in state government, including at KDADS and KDHE. So really I'm excited and pleased to be able to join you today. When we start talking about topics, I will say that KHI is sort of the expert role we're playing here is that we help facilitate other groups and in some of the same ways John has talked about, helping them come up with recommendations. So what we'll try to do as much as possible is really honor their work and describe the kind of priorities that the various task forces and working groups have been developing over the last few years in some of these subject areas you're looking at. So with that little tip of my hat to a larger group of experts whose ideas these really are, that's me.
Great. Thanks, Carrie. Hina?
Good afternoon, everyone. My name is Hina Shah, and I'm a senior analyst at the Kansas Health Institute. I've been there for about 5 years, and prior to that, I worked at NORC at the University of Chicago as a senior survey director. And so, as Carrie described, it's really our work across these task forces and working groups facilitating their work and really being able to highlight some of the priorities and the conversations we heard and the rationales they had.
Great. Thanks, Hina. Mike?
Good afternoon. My name is Mike Garrett. I'm the CEO of Horizons Mental Health Center. We're a community mental health center in South Central Kansas. Our main office is in Hutchinson, and we serve 4 counties in addition, southwest of here. 3 of those are rural counties, and 1 of them is a frontier county. I've been with Horizons a little over 41 years. Started as a clinician, served as a therapist for several years, took on some administrative responsibility, and then became CEO of Horizons about 14 years ago. So I've seen a lot of changes in the landscape of mental health services in the state and how we provide those services. But thank you very much for asking me here.
Great. Well, thanks. Thanks to all of you. So the goal over the course of the rest of the discussion is, we'll stop at specific points on each one of the subjects to once we kind of lay a little bit of kind of foundation based on some of the research that's been done, as well as framing some of the, where the submissions fell and areas of need, really kind of open up to experts to talk in the appropriate place and give a little bit of understanding about from their perspective, landscape of needs, opportunities, trade-offs, and some discussion, particularly as we start going through some of the areas potentially to focus on or to not focus on. So with that, go to slide 15. We're going to start off in behavioral health. And so, you would have seen from the pre-reads, we leverage lots of information sources in order to help kind of frame the topics, as well as to understand kind of what interventions might be possible and how the submissions overlaid over all of that. But in this area, there are a few particular perspectives that we brought in from the Kansas Mental Health Modification and Reform Committee's Behavioral Health Strategic Framework, the Governor's Commission on Racial Equity and Justice Report, and expert thought partners from KHI Horizons. So that's some of the context in terms of what the team's been up to from a decision support standpoint to help support the process for this discussion. On slide 17, at the most macro level around behavioral health, looking at it against those filtering criteria, what you find at just a really macro level in terms of allowability, at least what was represented in most of the submissions would be allowable. In terms of alternate funding, this is an area where there has been some limited funding to date. However, there is potential for more in areas, for instance, like the governor's budget, but it hasn't been confirmed. In investment types, a majority of one-time submissions, not all of them though. And then some limited interventions could be more ongoing. And in some of the areas, there's kind of a definitional feel around on the workforce, like premium pay of, some folks may be skeptical as to whether the premium pay would lead to kind of ongoing cost increases or not. Panel principles, is it aligned with the panel principles? Yeah, a lot of opportunities for having statewide impact and evidence for need. And this is kind of what we had talked about a lot, starting back to the original fact pack. This is an area that has been an issue for Kansas. And even when you look at Kansas versus other states around behavioral health outcomes, it definitely is a place where it has been challenged. Slide 18, this talks about, okay, last time we did talk about, if you look across basic needs, access and awareness, workforce, availability and affordability, data and systems, and then break those out into the component areas, which we will, as we proceed in this discussion, this is how the submissions came out, both in terms of number of submissions and dollar volume. And, a few takeaways were that a lot of the submissions in the workforce and availability and affordability area, that represents a high volume of the dollars that were asked. And part of the driver of that is anytime you get into facilities, the construction costs are going to drive big numbers, often. But this was kind of how, behavioral health laid out in terms of from a submission standpoint. And on slide 19, getting to kind of a greater level of detail, and hopefully people have had a chance to kind of look through the specific submissions, but here's how they laid out in terms of, against basic needs through data and systems integration, the submission. So it's on the basic needs side, supported housing, one submission, 3 submissions, one around youth and family resource expansion, substance abuse and suicide prevention grants, tobacco control and prevention interventions, workforce, it's everything from premium pay to training to improve quality of care, all the way down to support for employee wellness and resilience. Availability and affordability had 20 submissions. A lot of that was around things like building new inpatient bed and clinic capacity, to things that were more process oriented, improving discharge process, and as well as grants to providers to increase capacity. So a range of things. Like I said, we'll go into those a little bit more detail once we've heard from the experts. And then on the data and systems integration side, that seems to be a kind of a systemic area of need and opportunity across all the areas in healthcare. So with that being said, let me hand it over to the experts and ask, and then we'll probably just flip back to the earlier slide is, how would you describe the landscape of needs? What needs are considered the most critical to address when, now that you've seen this and all your work in behavioral health? Where are there opportunities for broad solutions that could create systemic impact given kind of the focus of these funds? And how could the panel think about opportunities and trade-offs for one-time investments in this space? So with that, who wants to go first? Looks like Mike has unmuted.
Yeah, I'm more than willing to.
Great, thanks, Mike.
First of all, I'd like to kind of set a little bit of context as to why I think the current situation is in the situation that it actually is. And I'll try to do this quickly and then be able to answer any questions that the panel may have. As most of you probably know, in the early 1990s, the Kansas legislature passed a law, the Mental Health Reform Act, and that closed 663 beds that were ran by the state then. It ended up with the closure of Topeka State Hospital, closure of beds at Lawrence State Hospital, as well as Osawatomie State Hospital. Then I also found a bit of information that on the private side, in 2006, there were 412 inpatient psychiatric beds in the state, and in 2016, there were only 210. So almost half a reduction in that 10-year period from 06 to 16. And that left 873 inpatient psychiatric beds in the state. And I think what happened then is the funding was supposed to follow the consumer. That happened for about 3 years, and then it didn't happen after that. And I think we've all heard that over the last several years, our jails and our prisons have become the largest psychiatric facilities in our nation. And I think that's a direct outcome of those processes. I think there's been some other contributing factors too. We went through the economic downturn in 08 and 10 that really impacted our state, it impacted our counties. It impacted our funding for the uninsured. That was cut about in half. And then the state wasn't able to restore any of that funding until probably the last 3 years. And I think about 3 years ago, community mental health centers anyway had been restored to the 2006 level of funding. So that buying power of that $2006 wasn't quite as much as it was back then. So I think that there's been a really drain on the system, and we've been really struggling to provide inpatient care. And I think that the lack of funding has provided a lack of development of programs across that continuum of care, that we would have outpatient services and we would have inpatient services. I think a lot of data will show you that whether it's ED admissions, inpatient admissions, or readmissions have all gone up in the last several years for mental health consumers. I think they've also had more contact with law enforcement people, and that's what's led them to have more interactions with law enforcement people. I think the last 2 years have also been problematic with the pandemic, that it's increased a sense of isolation. I think it's also contributed to a lack of organization in families' lives. School was a big part of that, and that was kind of flipped on its ear with televideo services. And so I think there was a lot of contributing factors that have led to, one of the main concerns is the increased rate of suicide amongst youth, and really all populations. And so that's been a really source of concern that I think has been the outgrowth of the population. I think there's a lot of areas that would be compatible with the guiding principles of this panel. I think there's a lot of areas that could be used for prevention, on the suicide prevention, getting that education, not only to communities at large, but with teachers, those people that actually have contact with kids. There's programs now that have peers recognizing that for teenagers and recognizing early warning factors that may indicate a teen is at risk for suicide. I think there's also some early childhood programs that would be very beneficial. I know we do a program that's referred to as ABC, Attachment Biobehavioral Catch-up, and it's for kids 6 months of age to 36 months of age. And the goal is really to increase bonding, reduce stress in families, with the idea that we're going to prevent mental health problems later on in life. And from a provider's perspective, when you're able to do prevention programs, that's incredibly nice. We really want to be able to do those prevention programs. But talking about the issues with the jails and the prison systems, I think there's a couple of things that could happen. I think crisis stabilization units in local communities would allow better diversion from EDs. I think it would allow better diversion from jails. I think there's a lot of services such as co-responders and those kind of programs that would help reduce people with mental illness going into jail systems. I think that would also reduce and address some social determinants. So these facilities could be step up and step down. So I think it would reduce readmissions. I think also supported housing for people with mental illness would be very beneficial. And the way I think about that, it would be, let's say an apartment complex of 10 apartments. The residents would have mental health issues, be engaged in treatment, but we'd have staff at that complex all the time that would be able to help respond to mental health crises, as well as just some of those kind of maybe you might call them soft skills, how to be a good neighbor, how to get along with your neighbor, all of those kind of things that would reduce the need for law enforcement intervention. But I think it would also address those clinical issues of treatment compliance, medication adherence, those type of things. Now, there has been an initiative that started that I think addresses many of these items, and it was mentioned in the earlier document that was presented, and that's facilitating the development of certified community behavioral health clinics. That started with the Excellence in Mental Health Act back in 2009, and then really got speed with the 2014 Protecting Access to Medicare Act. And then about 24 states were allowed planning grants. Kansas was not one of those that submitted applications. From that, 8 states were given demonstration grants to develop their community behavioral health clinics into CCBHCs. Then in 2019, which was really exciting, individual CMHCs were able to apply. Prior to that, states had to do it. And so in Kansas, we had 6 CMHCs that applied. Horizons was one of those. And of those 6, only one was awarded a grant through SAMHSA. But luckily, in the next 5 to 6 months, the other 5 received notice from SAMHSA that their grants had been funded as well. And so Horizons received that grant, and we started our grant on February 14th of 2021. So we're just a little over a year into the grant. But that's been a very beneficial program, and the Kansas legislature has supported that initiative with House Bill 2208 in the last legislative session that was passed with overwhelming bipartisan support. The Senate passed it 34-4, and the House passed it 120-2. And basically that said that there will be 6 community mental health centers become CCBHCs by May 1st of 2022, and Horizons is one of those. And then 3 more by July 1 of 2022, then 9 more in 2023, and then the remaining 8 in 2024. One of the things that I think is very beneficial is that the CCBHC initiative addresses all of the items that are almost addressed in the documents that we reviewed. Staffing issues are part of that. There's alternative payment models that will allow for fair market value compensation to our employees. It will take a time to build up. You have to address availability and access to services. Care coordination is a critical piece, whether that's with our schools, whether that's with jails and law enforcement centers, whether that's with primary care, whether that's with emergency room departments. You have to provide a wide scope of services. Medication-assisted treatment program for substance abuse programs, ACT teams, which is assertive community treatment to help those individuals with severe mental illness that are having severe symptoms. You wrap a lot of services around them for 12 to 18 months with the goal of stabilizing them and reducing the likelihood of higher levels of care, whether that be in an inpatient unit or that be in a jail system. But we also have to report quality measures. And I know that part of the criteria is, are the programs going to be measurable? Are outcomes going to be assessed? We have to provide that data already in terms of several of the outcome measures. And then a very interesting piece with CCBHCs is the governance and authority over the organization. And you have to have consumer input on your board of directors, which I think is just excellent, that you have to have those people that you're serving be part of your governing body. So I think that's great. I think that that model provides many and meets many of the criteria. I think if that CCBHC model could be infused somehow to get kind of compress that timeline, not so much in 2024, but move that to a shorter time period, I think we could impact a lot of things, whether that's suicide rate or helping divert people with mental illness into care rather than inpatient units or jails. I think I'll go ahead and stop there. I've used about 10 minutes and I want to be respectful of everybody's time. And I would appreciate anybody's questions that I can try to answer.
I can chime in now too, but I wanted to defer to John, see if he had any guidance for us.
Yeah, Carrie, why don't you add some thoughts as well? And then my guess is some of the questions may probably come up in the context of some of the slides that we go through when we look at some of the potential interventions. Thanks for the point of view though, Mike. That was super helpful for me.
Great. And Mike, I think covered quite a few of the things that I was going to talk about too. So I'll maybe step back and do a high level sort of thematic approach to it. What we have, KHI has had the role in 2017, 18, and then in 2020 and 21 to work with 2 mental health task forces through the Department of Aging and Disability Services and 2 special committees on mental health modernization reform sets of working groups. And it's really interesting when you look at the recommendations that came from those reports, which all built on each other and built on previous reports and other work of other commissions like the Governor's Behavioral Health Planning Commission. You see a lot of consistency between the needs that were identified and what you see in those processes, what Mike just described and what you see in your submissions, as well as in the opportunities. There's a lot of consistency. So the high level needs, if you think about the themes of the last few years, when people think about the needs in the behavioral health system in Kansas, Mike talked about it, inpatient capacity, significant need. Community capacity, though, too, as well, for crisis services, crisis intervention services. Prevention, particularly suicide prevention, is very top of mind for the folks that are working on these task forces and panels, people working in the field and who have been impacted by the lived experience. They also talk about the continuum of care. Mike talked about that a little bit overall, but particularly for children and youth. And I think there's some recommendations that probably relate both in early childhood, but also in behavioral health, including those aging out of services and some interconnection with the child welfare system. I think those are some really key issues that are also very key needs that have been identified over the last few years that share the theme that you're going to hear probably today in each of the focus areas, which is investment in capacity and infrastructure and workforce. Because supportive housing, that's another, has been a key element or a theme that has come out of many of the working groups. But in each of those areas, when we're talking about capacity, those are all sort of the primary capacity areas. There's also geography specific or rural specific or equity issues that might be related to all of those. So I think that really ties into what you all are working on as a group. Within workforce, there's been a lot of focus on the need for a career ladder and support for recruitment and retention. Mike also talked about some of the impact of interaction with the legal system and law enforcement. That's related to inpatient capacity, but it's also related to things like the access to competency evaluation and restoration. That was a big issue with the special committee this year, and they had members from the judicial branch that were also represented. So you have folks that are waiting many months in some cases to get a competency evaluation, sometimes even longer, we heard, than the sentence might be for the crime that for which they're accused. So what are some of the opportunities that seem to line up with what you guys have received? And some of the work that the special committees and task force have done. That system transformation that Mike, that you all are talking about, and Mike described, including regional inpatient capacity, that is something that's been a consistent theme throughout much of the work in the last few years, as well as expanded crisis intervention services. So very consistent theme. And also I see it's sort of a theme in the submissions that you all have received. A focus on integrated primary medical and behavioral health care as well, whether that's, and Mike described in good detail what the certified community behavioral health clinic model is, and sort of the seed grant. The idea is potentially for seed grants to help those who didn't have the initial SAMHSA grants to be able to build up capacity to fulfill that role, because it is an expanded role. It's like there's an expanded core set of services that CCBHCs fulfill. There was also a lot of discussion around telehealth. I didn't see necessarily a strict telehealth submission, but this may actually relate to one of the other panels as well, because the discussion around telehealth also brings up real needs for or recognition of issues around access to broadband, and whether that is access to the devices or the connection, basically, or the ability to pay for that service in order to be able to actually use telehealth services and telebehavioral health services. There was in the special committee report and in the working groups report, a recommendation for a workforce investment plan that the committee heard from folks from the state of Nebraska that had a multi-year and started with a plan, and then has had a development in workforce development in behavioral health. So they were interested in learning more about whether Kansas could do something like that, including some initial upfront work to sort of research what that model would look like, working potentially with a university partner somewhere in Kansas, potentially. They also talked about seeding programs to expand bachelor's and graduate degree programs in behavioral health in Kansas, as well as expanding associate level practitioner roles, establishing those, creating a pool of funds for behavioral health providers to use for recruitment and retention. And then all within the sort of a framework of a grow your own model, potentially for workforce, including a behavioral health workforce that represents the community, it represents the diversity of the community it's serving. So those were some of the key themes when the groups were talking about workforce investment and really developing a strategic plan for workforce investment, putting that work in up front and then really investing. A couple other issues. I didn't see anything related to this specifically in these submissions, but there was a lot of interest and has been interest in expanding the use of specialty or problem-solving courts. So you may be familiar in some of your communities. Some communities might have a mental health court or a veterans court or drug court, for example. So expanding capacity for individual districts to be able to have those kind of courts, and or providing a regional opportunity for specialty courts. And then finally, I think it's very consistent with some of what you've heard as well. A key theme is to try to, as much as possible, provide services where people are. So in some cases, that might be school-based services. And I see you've got some submissions that were related to that as well. So those were, I think, very much in line with what Mike was talking about. One of the questions was about trade-offs. And I think this is something that might be helpful to keep in mind, that the group, you probably will keep this in mind because you're being very thoughtful and have a lot of criteria that you're applying. But one issue that has become a common theme in the work of these task forces and working groups and committee is that sometimes a tension between investment in inpatient capacity and what that means for community capacity. So there's sometimes it can be a concern that you get a heavy investment in inpatient capacity, like in state hospital beds or regional hospital beds, that might mean that community capacity doesn't get the same level of investment, or that its support for it erodes over time because you've got this other facility that you have to continue to support. So, one thing the panel could do is keep that in mind, take that into account, and ensure that investments in behavioral health are balanced really across that continuum of care. More work in the community has more prevention and prevention on the front end, and community services could lower the demand for inpatient beds. Yet there's surely, and very well identified by the folks on all these panels and workforces and working groups we've been on, a need for inpatient capacity as well. So I'll stop talking and open for questions. And Mike, I hope I piggybacked appropriately on your comments.
All right, well, thanks, Carrie. Like I said, as we go through some of the specific areas, we're probably going to get more questions as well. Hina, did you have any thoughts you wanted to provide across behavioral health?
Thanks, John. So Carrie actually provided the thoughts across the task forces, but I'm available for questions as you talk through it. I don't want to take more of the panel's time.
Appreciate that. On the, and by the way, and for everyone, in terms of timing, we expected that it would be probably about 1 o'clock when we kind of got through behavioral health. So we're right on track. So this is awesome. So in terms of, now that we've, kind of have heard from the experts, kind of more holistically around the opportunity on the ground, we want to go through the slides that were in the pre-reads. And what we did, just to kind of set it up once, the way to look at these slides is for each one of those programmatic areas that we talked about before, identifying some potential interventions. And those interventions represent, and you'll see with the check marks, either things directly from the submissions or things from other sources of information, like the Kansas Behavioral Health Strategic Framework, as well as the Kansas Racial Equity Commission. And so the goals for the discussion on each one of the slides, so I'm not going to try and kind of repeat it on every slide that we go through in each one of the areas. And then, for each one of the topics is, which, if any, of the program areas are most important now, given all the information that you've seen and your individual expertise, and kind of wearing your integrated hat, which, if any, do you think should be removed from consideration, at least for this set of funds, and how we think about them? Be thinking about which would benefit most from a one-time investment, which programmatic areas and interventions align best with guiding principles, and which does the advisory panel want to explore going forward? So basically, the way to look at this is look at those potential interventions against these areas, and let's spend a little bit of time talking about, to people on the panel, are there places where you start seeing kind of areas that you really want to kind of hone in on for fleshing it out moving forward, or areas that you think kind of really don't fit here, either from a need perspective or from the perspective of just what this set of funds needs to focus on. So with that, I'll kind of open it up to the panel to start some of those discussions.
This is Sean. I'll start. I think there's a huge need for supportive housing on a number of different fronts, not only in behavioral health, but other the sectors we're going to consider as well. But I do have a question either for Mike or Carrie, or certainly Robin as well, is what's been done on this front in Kansas within the behavioral mental health system the last number of years, if at all, and how do we prevent kind of that cliff of the ability to use one-time funding without creating a need for ongoing funding that no one can commit to with this particular initiative with supportive housing?
Sean, I appreciate the question, and I can say, but I think Carrie will probably be able to be more definitive about it. But I know that there's been an initiative with Housing First in Kansas. But I think one of the challenges is, at least as I understand that program, it was time limited. It was only like a 2 or 3 month program, and then you had to graduate those consumers. When I think about supported housing for mentally ill individuals, I think of a much longer, this becomes their home, and we're providing ongoing support for them to be able to remain in that home. So I think it needs to be expanded and made more available. In terms of sustainability, I think the initial investment is a big challenge. It's a pretty heavy lift. With the community mental health centers moving towards a CCBHC model, it also provides cost-based reimbursement, which is a real game changer for community mental health centers. Our Medicaid rates have stayed stagnant since 2006. Under a cost base, we'd be able to start to learn to be able to absorb that cost of that ongoing service for that supported housing. But to get it off the ground now, an infusion of money would be needed.
So, what do people think about the access and awareness in general in terms of, the interventions that are here, the potential ones, and community-based resources and navigation and prevention?
I mean, they seem to. What I'm struggling with is that everything is so important, and that just seems to have been emphasized by the folks that have presented today. I really think it's helpful, though, to have the check marks to show, where each of these things sort of fell within the prioritization of some of the materials and guiding documents that we were provided with. And so I guess I would just, lend some support to the youth and family resource expansion as something that we should focus on, given we just are hearing over and over and over again that one in particular, there's an area of great need.
Okay. Any other thoughts?
I agree with what McLean just said, that the youth and family resource expansion, there was a lot of submissions in that area, and that really seems to be an area that we need to focus on as we think about how to use these funds.
Great. All right, well, let's move to the next slide and kind of go through we're going to have a lot of landscape to cover today. So, we're not going to be able to potentially give each individual slide as much time, as it might warrant, at least at this step in the process. So why don't people kind of take a couple minutes to look at these ones, and then maybe like at 12:56, I'll ask people to say, okay, are there some areas that people see as kind of rising to the top as maybe a high priority to continue to kind of pursue fleshing out for this set of funds, and some maybe actually even that might need to be deprioritized. Just, from the previous slide, what we heard was, housing, youth and family resource expansion are kind of areas, where we heard some particular area of focus going forward. Nothing really deprioritized necessarily specifically, but just curious as to what people think on this slide. So maybe take a minute and then we can talk about it. All right, anyone want to kind of throw their hat in the ring first with any thoughts?
Yeah, sorry
Go
about
ahead,
that.
McLean.
I was just gonna say, you're having mentioned housing as a support was particularly resonant with me, just in our work at Health Forward, and talking to some of our partners, in urban and rural areas in particular. The workforce issue is often married with the housing issue, and so viewing this as an opportunity to sort of kill multiple birds with one stone in terms of increasing the workforce, the economic stability of the folks who are provided with these employment opportunities, and then housing as an additional support to layer on that is of interest to me as a way to kind of stretch the dollars that we have.
Yeah, I will say we have heard housing is an issue in general. The previous housing, though, was more targeted around, specifically behavioral health, but certainly have heard housing is an issue from every one of the panels in a variety of contexts.
John, do we know, I think we talked a little bit about this at one of our previous meetings, but do we know how much money has already been spent specifically in the premium pay and recruitment bonuses area?
Does anyone know, just on the support team off the top of their heads, what the amount of that line item was?
John, this is Andrea with the Recovery Office.
Yeah.
The first Spark allocation for the $50 million, and that program ended at the end of February and should have been all dispersed at that point.
Yeah, and I would be curious to know, and I get that this probably adds a layer of some extreme difficulty, but there's been some philanthropic dollars that have gone toward providing recruitment bonuses and other sort of stipends to attract and retain behavioral health workforce, specifically in the Kansas City region, is what I'm recalling through the Greater Kansas City's COVID fund. And I'm thinking it's only something around, $1 million, which is a drop in the bucket in the greater scheme of things. But there's some other dollars at play that we might at least want to try to consider as we're thinking about where our resources might be best put to use.
Mm-hmm. As I mentioned before on the premium pay, and I'm not an expert in any of these things, is that on the premium pay, I know that it went through previously. There has been, I've heard a few times, people, questioning whether when you kind of establish the premium pay, are you going to kind of make it hard to retain folks beyond that premium pay period? I don't have a point of view on that myself. That was just a point that had come up in previous discussions.
I do have a point of view on that, and it feels like you just continue to feed the beast, if you will. I absolutely understand that our behavioral health staff and our hospital and healthcare staff have been working incredible numbers of shifts. But when you do that premium pay and those bonuses, then it becomes very challenging, and you do that for extended period of time, then it really creates a lot of problem when that stops. Because maybe for even up to a year, people have gotten used to that. And at least in the hospitals, we see it work to some extent, but I mean, I can't tell you the number of people who stayed until the second Spark payment was made, and then they resigned a week later.
Mhm.
So maybe it helped us keep them retained for the 3 months in between or the 2 months in between, but long-term, I don't see it working.
Well, given that, Robin, in the workforce area, would you see maybe even thinking more from an emphasis standpoint on the pipeline development than the recruit and retain, or?
I think the pipeline development is huge. I feel like in behavioral health and healthcare overall, we have kind of sat by for the last 20 years and watched all of the STEM activity steal kids from starting in elementary school. And some of those, I see Mike nodding, some of those kids might have become nurses or social workers or addictions counselors, but they've all gotten recruited at an early age into STEM, and we have not done anything like that in healthcare.
Mhm.
And so what I would and I keep saying this in every meeting I'm in, I think we need to get organized, at least within our state. Commissioner Dennis suggested the other day that we probably need to work with the State Board of Education, because that's kind of where STEM got started. He was on the state board at the time. And how do we get into schools to start that pipeline development with kids? And that's bigger than throwing $1,000 at, some staff that will be good for that moment, but 3 months later, they're going to forget they got that $1,000 recruitment bonus or stay bonus.
Yeah. Okay.
One of the issues will be that it was already provided in the hospital, so there's somewhat of an expectation there, incorrectly or not. But I'm going to sound like a broken record every time we go through a slide and talk about workforce. That I think it needs to be a broader discussion for healthcare in general, so behavioral health, long-term care, kind of all the sectors, and have a more holistic conversation about it instead of each time going through it.
Yeah. And I think we'll set ourselves up for that discussion once we've gone through the individual. I think we're going to see that, there are some common themes around all of these things. But we wanted to get into some of the specifics where we could leverage some of the expertise, but hear you there, Sean. Appreciate that. How about an availability and affordability in terms of facility or program expansion or provider operations? Anything here that, people see more with a thumbs up or a thumbs down?
There's been a lot of talk over the years about the inpatient bed capacity, and Mike referenced it, and then the crisis stabilization and intervention capacity as well. It'd be helpful to me, at least, to know kind of what's been done the last number of years, in what parts of the state, and what either the task force that Carrie and KHI facilitated have said is a need, and what's still there now in 2022. And I know there's a couple of additional things that the legislature are considering as well, the governor included in her budget.
I think we'd be happy to provide both the sort of what the current or most recent focus has been, and then I think we could work with KDADS and with the facilitators here to get the sort of year by year. You can see what those investments have been. We did a few years ago as part of the mental health task force. We did map out capacity we did it a couple different ways geographically, including by CMHC region. So, but it would have to be updated definitely to take into account new beds, new providers, new service levels, particularly the crisis intervention centers, some additional capacity there.
I think Mike touched on that in his comments. If you go back, and Mike, I'm not going to paraphrase it. Why don't you just say that part again, where we were 10, 20 years ago and where we are now?
The information I had, Robin, talked about, one is the reduction in state hospital beds in the 90s, but in 2006, just on the private side, there were 412 beds in the state, and in 2016, there were 210. The other thing I would say, and I'll use Hutchinson Regional as an example, we provide services on their 15-bed inpatient psychiatric unit. But due to staffing shortages at the hospital, we have a census capacity now of 6. So I think the workforce issue ties very intimately to the inpatient capacity. Larned State Hospital is the same. They have a budgeted capacity of 90, and I get daily reports. Their census is 68, 69, and they have a waiting list now because of workforce issues.
The Mental Health Task Force report a couple of years ago had used the waiting list and the time to access services at the time of Osawatomie State Hospital, but basically to be able to access them at state hospitals, and try to measure back how many beds would need to be available to ensure there was no more than, like, you wouldn't wait a whole day for a bed. And at that point, and this was assuming no other changes, like at the community level or community regional beds and so on, it was about 200 beds. And there was a proposal for immediate, I think it was 50, may have been 65 bed, and then up to 200 to 220. But that goes back to my earlier point about the tension too between the inpatient and community, because that same task force said it was really important. It's like, that's how many, if you don't invest in a lot of other community interventions, and there's that number could be reduced if you would invest in more crisis intervention centers and so on. So that's, I think that interplay is always there.
So how do, I mean, if the needs there, how do people think about those potential interventions that are listed?
This is Kathy Decker.
Yeah.
And I noticed that it talks about the schools having programs. And I know a number of years ago, there was a program started, and maybe Mike can even tell us more about it, but it was the school mental health intervention. And it started with 9 districts, and now it's in 55 of the school districts. Do we have any information showing statistics on any of those, where the kids are receiving that intervention at that time through the schools?
Kathy, I think that would be absolutely amazing information to have those outcomes. I will just say, and this is totally anecdotally, here in Wichita, I have a lot of friends and colleagues who work in mental health and in education. And the feedback I hear is there are behavioral health people tripping over one another in the schools. Which I would say from a hospital perspective and a behavioral health perspective frustrates me, because we lose a lot of people to the schools because they make as much money there in 9 months as they make in my inpatient hospital in 12 months.
Yeah.
Yes, and that would be another, and that's probably not for this group, but I think that if you are giving mental health services in a school, it should be 12 months. It should not be 9 months.
Great. Well, let's, in the interest, so let's go to the next slide so that we cover some more of the areas. Any thoughts around the enablers? I mean, these seem to be areas that could have systemic impact. The question, though, is, what are the thoughts around where this sits in the kind of context of all the other areas, and are there any kind of potential interventions here that people think are particularly compelling for this set of funds? Anyone?
I believe on there that they expand the telehealth access is important, especially out here in Western Kansas.
Yeah.
Because in our smaller communities, I mean, that's all that people have sometimes.
Mhm.
And so I think that because we don't have facilities, we don't have mental health places that are close where people can travel to. So
Yeah.
I think this would be very helpful.
Okay. Any other thoughts on this before we move on? Okay, great. Well, in the interest of kind of getting through, I'm going to continue to move on. So appreciate that. Once again, this is a lot of stuff and complex issues, but kind of want to move on to some of the others. So in health, once again, kind of leveraged information from a variety of different sources to be able to think about the submissions, as well as any other potential levers to be able to, from an intervention standpoint, in order to be able to pull. Go to the next slide. So the situation in health, just in general, broadly, was a little different than it was in behavioral health. Most of the things, or a lot of them, would have a pathway to allowability. The question in a lot of them was, in terms of alternate funding, how do we think about the context here, given that a decent amount of funding has gone in this area? Certainly not to say that there aren't needs that still exist, because there certainly are. But it has received more funding than potentially areas like behavioral health, but it's a broader area too. Investment type, there are some one-time submissions. A good amount of them could represent ongoing needs. In terms of the panel principles, 40% focused on statewide impact, 20% in the Northeast, 18% on South Central region. Some opportunity for broader solutions around the basic needs. And then evidence for need, certainly as within all of these areas, there is an evidence for need around the healthcare system in general, which has been stressed over the last couple of years for sure. Go to the next slide. We talked about this last time in terms of kind of where things fell. A really big bucket was in availability and affordability, which is once again what you'd expect on anything that required construction. Majority of the count, of submissions and social determinants of health, focusing on social services. So go to the next slide. I think you should have seen this in the pre-read. So in the interest of time, I don't know if it makes sense for me to go through these in detail. A number of submissions on the basic needs side, a lot around homeless issues, as well as food access, low income support, access and awareness on workforce. Once again, the premium pay issue, the pipeline issue as well. The development issue existed here as well, to Sean's point around, there are some things that are going across all these aspects of healthcare. Availability and affordability, a range of solutions, anything from hospital decompression to medical education centers, patient step down, transition to community-based settings. So looking at the continuum of healthcare. And then once again, also submissions on the data and systems integration side. And we can come back to this after we've heard from our expert in this area. So if you can go to the next slide. So is he here at this point? David, great. So David, why don't you do kind of a quick introduction and kind of give your kind of view on the landscape of the needs in healthcare broadly, and being able to think about some broad solutions that could foster a long-term systemic impact that we should consider kind of with this set of funds.
Excellent. Thanks, John. And thanks to the panel for inviting me to this important discussion. I think there's a lot of overlap between the mental health theme and the health theme, and there's a lot of landscape to cover. I really appreciate the the focus of in the principles of the commission and prioritizing sustainable programs and looking at flexible strategies and longer term systems impact. Coming at this from being the CEO of a health foundation that serves statewide, but also cares deeply about rural, I see rural needs and then also sort of prioritizing the needs of changing Kansas are front of mind through the work on the Racial Equity and Justice Commission. I think at a high level, as we think about how we can use these funds to make long-term investments, just recognizing that while Kansas is a rural state, our demographics are changing. Only 7 counties grew at over 5% population between 2010 and 2020. In terms of looking out to 2064, we're projected to see just a 0.4% increase in population, and the fastest growing age cohort will be that of over 65, with 1/4 of our population being over the age of 65. Of the population that's growing, the population is communities of color. So there's long-standing disparities that exist. So I think the challenge and opportunity that we have with these dollars and resources is to think about how can we make investments now to both serve immediate needs, but also help create a system that's meeting the future needs of an aging Kansas, and also a Kansas that is more diverse, but both of which have higher needs from a healthcare standpoint. So how do we develop care teams in the workforce front? How do we make sure there's access there and financing to pay for some of this care, which I think fits in with some of these short-term investments that could have long-term impact. I think another thing to keep in mind as we think about access and basic services, Kansas is just about at the national average of uninsured rates, but our uninsured rates, both of rural Kansas and communities of color, are higher, the highest population. From a workforce standpoint, which I think we need to talk about workforce across all aspects of healthcare and mental health. So I appreciate the conversation earlier. What does a care team look like for serving rural Kansas? Might be different than the care team serving more populated cities. Kansas, in terms of nurses per 10,000, rural Kansas depends more, for instance, especially in nursing homes, on licensed practice LPNs and vocational nurses versus urban areas. But when you compare Kansas supply of nurses to national supply of nurses on a per capita basis, we're lagging both. So I think nurses is just one example of workforce. And I appreciate the conversation about how can we build a pipeline, because I think that's part of the piece. And I think it's how can we leverage dollars to be a bit more innovative in how we approach things like aligning high school programs, community college and region programs to graduate students, to put them to go from LPN to RN to BSN. How can we make sure that those pipelines are in place? Not just for nurses, but across healthcare professionals, because we know we have shortages of behavioral health providers, social workers, primary care providers, and we really need to be thinking in a teams-based approach. There's a short-term shortage of workforce due to COVID-19. We're seeing the speeding up of baby boomers retiring. There's just a more desire for more flexible work. And then there's just different needs in rural communities. At a high level, 3 in 10 healthcare workers, so not just nurses and doctors, the orderlies, rad techs, have said they are considering no longer working in the healthcare workforce. So there's some retention there, but I think we do need to look at the supply as we look at these dollars to have the most impact, not just for the short term, but for the long term. More than half of nurses surveyed under the age of 40 are less committed to the profession than a year ago. So I think there's also, are there things that we can do to make healthcare more enticing? Again, not just for the short term, but for the long term. Workforce shortages are having an immediate impact on patient care. Hospitals are reporting limited services due to staffing shortages. Elective surgeries have been canceled. Overnight surgeries have been canceled. Limited number of swing beds are available. increased nurse to patient ratio, and transfer issues exist. So, this workforce issue is front of mind. And then, I do think it's important that, we take a step back beyond some of the more traditional access buckets and just looking at social determinants of health, recognizing that health is more than healthcare. We talked about housing as part of the mental health discussion. Obviously, behavioral health is a big piece of it. If you look across our health rankings, just more generally, factoring in healthcare, education, mental health, built environment, and then other clinical cares, Kansas has decreased more than any other state over the last 30 years. But just in terms of short-term decreases in health outcomes, we now rank 33 in the country. So how can we make the, leverage these dollars to make the best investments, I think is the question we can be charged with. And I certainly think that there's some pressing needs in terms of access that I didn't see surface in some of the recommendations at a high level, though I don't have the luxury of looking at them as in depth as you, and I'm happy to go through some thoughts for each bucket. But under the access to care piece, I do one thing to keep in mind is beyond the existing uninsured rate, we expect the public health emergency to wind down in mid-July. We haven't been churning folks off of Medicaid over the last 2 years. So there's a likelihood that we're going to see a jump in uninsured rates. So I think leveraging one-time investment in dollars to pay for increased outreach, enrollment, and education to both support the safety net clinics, the CMHCs, the hospitals, community-based organizations, and the MCOs and Medicaid as they try to deal with the public health emergency, I think would be a prudent use of dollars, not just because it would be short-term measurable, but it also would be a way to make sure people continue to have coverage and cares financed, and it would be a good leveraging and creating of dollars. On the workforce front, I appreciate it, as I mentioned several times, sort of how can we build a pipeline? And I do think there has been some work within the last few years to leverage Board of Regents Promise scholarships. I think how can we expand programs and align interests so that we can be taking, community college credits in high school and the health professions? How can we then make sure that those credits are accepted at the community college level? And then you can move up and create pathways with bachelor degree programs and beyond. And I think this can be explored. Nursing is something that's been latched onto, but I think we can explore this across the health professions. And it would be an innovative approach, but there's some other states to learn from. So I think if that type of approach to workforce makes sense, we could look forward across the healthcare spectrum. I do think on the workforce front, that touches on availability of services, both in mental health, healthcare in general, and then also I'd say within child welfare and preventive services is how can we build a team that delivers care in community and home-based settings is important. We're just starting to, as a state, dip our toes in the use of community health workers. We have several large federal grants, philanthropies funded community health workers. And there's the longer-term issue of Medicaid reimbursement. We're not there, but culturally competent community-based workers like CHWs can be employed across a number of settings as good home visitors that both help people connect to services, help them navigate systems, but also prevent costly emergency room visits, or in the case of, say, home visitors, where you could sort of see partnerships between law enforcement and community mental health centers and school districts. You really can be doing some of that preventive work to reduce interaction with the child welfare system and the mental health system. So I think as we think about care teams and investments to stimulate innovation, we should be thinking more broadly than just the traditional healthcare system. But we do need to pay attention to other healthcare staff that are working in nursing homes, that are working in hospitals and rural communities. I was talking to a hospital administrator in Clark County last week, and then in Greeley County, and they were saying the biggest challenges they have is staffing their long-term care, even more so than the hospital. So I think that the LPN staff there is critical, and there's some pathways to explore. While not pertinent to the healthcare submissions that I had seen, just two more quick things to highlight is I appreciated the telehealth recommendations in the mental health report, and I think there's connection. We did a statewide survey last year. We found that 87% of Kansans wanted to see the expansion of telehealth, not just the maintenance. So I think that that's one place to look, and there's short-term investments in infrastructure that could be used to help be a bridge in funding. And I think both in terms of technology, some training, and then maybe even some ways to invest in workforce to help navigate setup for patients. And then in terms of the crisis response piece, I think that's come up both as part of the Commission on Racial Equity Justice, aligned with mental health modernization, aligned with a lot of the other work that Carrie talked about. I think there's ways to explore virtual crisis response and other virtual co-responder models and crisis models. So I think there's a strong need for that, both on the preventive front, which is going to benefit the overall healthcare system for sure. So there's probably a lot I could talk about, and I probably talked a little too fast. So I'm happy to answer any questions or go more in depth on anything that's helpful. I appreciate the opportunity.
Thanks, David. Any questions for David?
One other thing I just highlight, which is just in terms of the recommendation, both in healthcare and in mental health, is looking at data sharing and data tools. I mean, I think to the extent the state ultimately could sort of look at, aligning their payment systems for social determined self, I think that's exciting and could happen during the next reprocurement process. But I do think there's a huge need out there to be doing screening for social determinants of health and making referrals and having a both care coordination and closed loop referral system. I know that was part of the proposals for this group. I think that would be a strong investment to both more efficiently coordinate care and also be taking sort of baby steps, big important steps through data to getting to sort of looking at the broader paying for social determinants of health. So I think that is a worthy investment. I do have a question as to whether or not some of those costs could be incurred as part of reprocurement with a state federal match with Medicaid, but I do think.
Great. David, you were going in and out there a little bit at the end. But before we move on, anyone have any questions for David? Well, okay, we'll continue to move on, and I'm sure that as we go through the particulars, the one thing, David, I'd say was really helpful was not just the overview, but that you were able to kind of target in on some of the most important areas, maybe the highest leverage areas. That was super helpful, at least for me, and I'm pretty much a novice in this area. So as we get into the areas, basic needs, access and awareness, and looking at the potential interventions that had bubbled up either from looking at the submissions or the Kansas Racial Equity Commission. Once again, just open it up, take a look for maybe about the next couple minutes, and then, let's have a talk about, are there some of these programmatic areas that seem to be areas that kind of draw the most focus, and some potential interventions in particular that either people think good use of focusing on with these funds, or potentially, not an area that probably fits, how we're thinking about this set of funds.
I've got a question, just because I don't see the, oh, no, never mind. I only saw the 2 check marks up top rather than 3 from the previous slide. So I was wondering what was missing.
Yeah. So I guess, any thoughts around these? So for instance, I'll just, once again, I'm not an expert here and I'm not the one making the decisions. But, all of these things are incredibly important. So, but, would sports facilities and programming rise to the top of the list for folks under access?
No.
No, important, very important, but it doesn't hit the top of the list for me.
Agree.
Things in the top box, basic needs, I would struggle to say which of those isn't a priority because
Mhm.
every single one of those is important.
Yeah,
The three at the bottom, although expanding multilingual navigation and care coordination support, I think is incredibly important, but the other two I struggle with a little bit.
yeah, at least for this set of funds.
For this set of funds, right,
Yeah.
all important, but for this set of funds.
Mhm. Any other thoughts?
I just echo what Robin said.
Mhm. All right, well, before we move to the next area, any last thoughts on this? You know, David, curious whether you have any thoughts?
And I agree with the comments made by Ms. Chadwick and Ms. Macklin. I do think the expanding navigation and care coordination support could be not just a way to improve access to care, but also, if constructed the right way, could help with some of the challenges that we're going to face with the public health emergency wind down. So this role could be both building access to navigating a system and better delivering care at lower cost, ultimately reducing emergency visits, as well as like helping people make sure they're not churned off of Medicaid. So we're not ending up with more uncompensated care in our state's hospitals and in our state's community mental health centers and safety net clinics.
Great. All right, you got next slide. Around capacity. So take a look at this. In a couple of minutes, I'll start getting kind of same drill, you know, areas, either the programmatic areas that people feel the highest leverage. I think we'll probably have a good feel for that. And then maybe even some of the interventions most important, or ones that, once again, may just not be as much of a fit here for this particular situation.
I just building on sort of David's comments around community health workers and just the various ways that they can be utilized in the whole healthcare system, and all the different supports that they can provide to people, as well as the referrals they can make in the course of, you know, the relationship that they have with patients, would, I guess, prioritize that one amongst the others in the workforce area. We're working with community health workers in the Kansas City area to also be digital navigators to help the patients that they're working with get better connected to broadband and, you know, the whole World Wide Web and all the resources available therein, not just limited to telehealth access, but just accessing the 21st century economy. So it would just seem that an investment in this area would reap a lot of benefits.
You know, in that whole workforce area, as you read through the submissions, there's a lot of different entities requesting funding for those interventions. One was a certain amount of money that was going to help 5 nursing students in a year. And those onesie twosie things are important, but what I think as a state and as a group we need to do is figure out, how do we have a broader, more intentional plan to spend money and funding, rather than this county gets a little bit and this community gets a little bit and this organization gets a little bit. That just doesn't seem to me like it's going to bring about systemic change.
Yeah. How do you grow the pipeline by 20% of the next 10 years?
Exactly.
Yeah.
So while I hear each one of those organizations, and I know Sean has spoken to that too, that we need to help in some of these different specialty areas, I think we've got to step back and take a broader perspective of how do we really build this for long-term sustainability.
Great.
I agree with what you said. You said it better than I have. So thank you.
David, it looked like you were getting ready to unmute there for a second.
Well, I agree with both the comments of the commissioners. I think, is there ways to use these dollars to incent scholarships in key areas, but from a systemic standpoint when, I said this several times, where there's alignment between secondary education, community college and Regents institutions. And then I think, can we incent creative ways of delivering care? Other states have, health professional shortage pilot projects that they're enabled. So, can we test innovative pilot models with different providers that may not be part of the team now? Paraprofessionals that offer good career pathways but help you deliver care in a real way in rural Kansas. I think that there's ways to maybe think about leveraging those dollars to create innovation, both on the training front and the deployment front. That could be interesting, and beyond those comments are probably above my pay grade.
Great.
In the bottom box, when you think about some of those topics, we have heard multiple times that we have facilities that are old and strained and not built for the capacity that they handle now. So on that availability and affordability, I would just say, I think we do need to take a look at some of those infrastructure pieces.
Mhm.
Because we need both people and we need space for the people to treat patients
Yep.
and clients in.
Were you talking more from an overall capacity standpoint or looking at the state of the current capacity?
Really both, John.
Okay.
I think we need some increased capacity. I mean, we went back and reviewed how many beds we used to have, and we've got half the number of beds 10 years later in 16. And then many of our facilities that provide services, they're just not able to manage the capacity they have.
Mm-hmm. Got it.
So both.
Representative Williams, it looks like you're getting ready to weigh in on some. Oh, you're on mute.
Thank you. Sorry about that. A little bit off topic, but still on your slide for capacity, availability, affordability, facility or program expansion, workforce, recruitment, retention. I mean, my comments have been said before. I mean, we've discussed this, but from a legislative standpoint, my big concern is I look at this and I think that ongoing cost, who's got the ongoing cost? And that's honestly of my fiscal perspective
Mhm.
of a lot of these. I mean, we can talk about all the virtues and priorities we want, but how much is this going to impact our local governments, our counties being local governments, and our state budgets in the future when we implement these? So I just wanted to let you know from the perspective of myself, and I think Senator Erickson had to step away, but it's really concerning how this could potentially negatively, and I say negatively, impact future budgets, because we are now, it's a sustainability issue. So I just wanted to bring that up in the discussion. Again, I know as we talk about the virtues of all of these things.
Yeah. Well, that certainly is a criteria that both this panel has expressed before, as well as the SPARC executive committee is going to be looking squarely at that in terms of the things that they get. So, focusing on the things that are, kind of catalytic investments with the set of funds, probably is the primary sweet spot for it. So. But, I think a lot of the stuff that we've talked about, most of it probably could be focused on that way catalytically. We're also going to need to be very careful of some things that may look like they're a one-time use of funds, really pressure testing to make sure that it doesn't drive ongoing requirements that can't be covered, right?
May I also say one more thing? As I look at the
Oh, you're on mute again. Got it.
Okay. Just the other comment is it's tough reading through all the applicants. because they're competing against each other. I don't mean for the money, that too, but I actually mean for staff. And it's just this endless, race to, I'll pay more, you pay more, I pay more. I see it in the school districts taking social workers away from the community health, mental health centers, or vice versa. It's just a constant competition. And I hope we fund in this committee, and I hope ultimately what's funded are those things that are not immediate Band-Aids, but long-term root solutions.
Yep. Appreciate, and I think some of the discussion that's happened around the pipeline actually could help improve that as well, right? Taking a strategic view towards that. So I don't know that that's necessarily inconsistent with that. As a matter of fact, that some of these seem actually to be in conjunction with that view. Before we move on, any other thoughts around on the availability and affordability side? All right, well, let's move on to the next one. David, you had begun touching on this around data and systems integration. So I guess, what are your thoughts around, particularly for a catalytic investment, being able to, with this, is this an area where with a kind of targeted investment can make a big difference, or?
I think there's a significant need for moving towards a system that can be used statewide, where we can do screenings based off of social determinants of health and other important health and mental health screenings that could then help us make referrals to community-based sources so people get connected with care earlier. We bring down costs, we have better data, and then ultimately looking at leveraging longer-term funding, federal funding, hopefully that's sustainable to the chairwoman's comments earlier. So I do think that this is a real need. I think the one question that probably just needs to be asked is there a way to do some of the data system, and it may also be that the answers the catalytic question, because I do think this could be catalytic, and I think it's great and needed. So I'd say yes. But then I think the question is there a way to braid funding, and can we access some data upgrades as part of as the state reprocures its Medicaid program? And did you take 90% of it being funded through federal dollars? So I wonder if there's how you'd braid the funding, but I think it could be catalytic, and I think it's needed.
Got it. And then I think we've also heard a few times around telehealth capabilities. So just wanted to capture that. Any other thoughts here? All right, well, we have two more areas to move into. And so I want to make sure we at least get a chance to cover them. There weren't as many submissions in these areas. But nevertheless, we're able to look through them, and certainly there's been a lot of work done around each one of these areas. So in the in terms of disability services, we're able to bring a couple other kind of expert source overlays. Go to the next slide. This is an area where, if you look at it, path for allowability for submissions, alternate funding sources, little bit of a mixed bag there, some increases in that area over time. Majority, though, of the submissions were one-time submissions, one-time investments, at least on the face of them. In terms of the panel principles, once again, possible for statewide impact. 78% of the submissions have statewide scope, but a number of point solutions as well in terms of facilities and programs. And evidence for need, certainly needs overlap with those identified in the other areas, particularly behavioral health. So continue. Next slide. Great. Not going to go spend a super amount of detail here. Most of the submissions came in the area of availability and affordability around facility or program expansion. Next slide. Once again, not lots of facilities and lots of submissions, but kind of here's where they laid out. Once again, a lot in terms of just the number of submissions and the availability and affordability area. Certainly some in the workforce area as well, and access and awareness. Go to the next one. So rather than having kind of an independent expert discussion here, the thought is to just kind of start getting people's thoughts as here we go. And Sean, you may have as much thoughts in these areas as anyone else, but we pulled on kind of 3 overlays: the submissions, the HCBS Intellectual and Development Disability Report, Kansas Behavioral Health Strategic Framework, and a Complex Needs Working Group report. So, and I guess if people look at this in terms of, basic needs and access awareness, thinking about kind of the data that was brought to the table, as well as some of the particular interventions, what are people's thoughts here in terms of areas to like really focus in on, or maybe areas that shouldn't be focused in on as much with this set of funds, given the guidelines around them.
I think we have a big need for additional residential care facilities for persons living with disabilities, and supported employment for sure.
Robin, this is Carrie Breffett. I'm glad you said that. I was about ready to pipe in and say, just in case people didn't know what that supported employment was, that has been a priority for many advocates for folks with disabilities to be able to, and there's a specific approach particularly to allow additional support, including funding, Medicaid funding and so on, to help recruit folks that will employ people with disabilities as well. So it has crossover into the behavioral health area as well. So I think it was interesting to see here, but it could be sorted into many other categories, kind of like with workforce.
Great. Any other thoughts on the slide? Go to the next slide. Oh, sorry.
I was just going to say, this is again anecdotal from one hospital, but the most challenging patients in our behavioral health units, the most challenging patients to discharge are patients that have especially IDD issues, because there's always a lot of acting out, and they get admitted into a psychiatric facility. And the resources in our state are just sparse. We can keep a patient with IDD in our psychiatric facility for months trying to find a placement.
Got it.
Would agree with what's been said. The challenge with all this will be what proposals are appropriate for the one-time funding where there's not a cliff. So maybe it's the expansion of integrated behavioral health, disability services on the availability, affordability box that you have. If there are some projects there that were proposed, that would be appropriate for the one-time funds.
Why don't you go to the next slide, since we've moved to it. So which one of these would have been, was that Sean?
Yeah, sorry. To Robin's point, the 4th bullet point under availability and affordability may address that one if there are any specific proposals that would help with that. Again, that would not have a cliff after the one-time funding.
Got it. Any other thoughts around? It sounds like probably the same pipeline issues probably, well, there's a pipeline issue here probably too, right?
Definitely.
For those of you interested too in thinking about the workforce, we've talked about challenges in rural Kansas for workforce across all the healthcare. I think this can be a particular issue for disability services, trying to find folks in rural communities, trying to find folks to support them living independently in their homes and communities. So there's a particular rural lens that I don't know if any of the proposals necessarily address that, but that definitely could have a statewide impact.
Great. Go to the next slide. Seems like here, improved integration across systems. And this wasn't necessarily something called for in the submissions, but it's been called for in some of the studies. So that sounds like a general issue that we've seen represented across each one of these areas. With that, we're going to need, I want to move on because we need some time at the end to, in the background, people have been trying to look at, across all of these various areas, which things have been kind of floating up to the top or not. I want to have a chance to revisit that explicitly with the group. But before that, I want to go through the senior category because that's one that I am fast approaching myself. So it's a particular relevance to me, although I'm not in Kansas. So on senior services, so once again, leveraged the state plan on aging for looking at into both potential interventions and as well as thinking about the submissions in the senior care task force. Go to the next slide. In terms of allowability, once again, path to allowability for most of the submissions. Alternate funding, there is some. Some had been directed to KDADs. Don't know, probably likely it wasn't sufficient. Investment types, a lot of one-time submissions. Panel principles, possible for statewide impact, 43% of the submissions of statewide scope, 29% focused in the Northeast. And then just a mix of some broad statewide and some point solutions to consider. Evidence for need, senior population has grown significantly, as have their needs, and it's projected to continue to grow. So this is an area that's just going to increase over time unless things change around the kind of population trends within Kansas. Go to the next slide. Once again, not a lot of submissions here at all. A few, though, significantly in the workforce area, the 3 in recruit and retain. Go ahead. Go to the next one, and let's just kind of take it kind of point by point. So around basic needs, people take a look at this around, social determinants of health and community-based resources, navigation, prevention, any areas here that jump out at people as one areas to really hone in on, or 2 areas that just kind of either not quite as important as levers or don't really fit the focus for this set of funds.
If it's helpful to the conversation, this is Hina Shah from KHI. The working groups that were convened by the Senior Care Task Force, I thought the vision statement might help set the landscape. One of the groups said, older Kansans will have access and the ability to choose and receive high quality, person-centered services wherever they reside. So one of the topics they are looking into is rebalancing of services, really allowing choice and thinking through what services can be offered if older adults want to stay at home. The PACE program and kind of leveraging that has been one thing. Another idea that's been proposed is thinking about senior centers that are available and concurrently using those as adult day centers. And so thinking through, what's available and really thinking through services in rural areas as well, if that's helpful.
So with that, are they thinking about a range across telehealth, home-based services, or someone comes to the home, or just more local community structured services?
Kind of a mixed bag of all of those, especially in with workforce, of course, those same themes, right? Of workforce investment and investment in infrastructure and capacity. But yes, definitely rebalancing of home and community-based services, expanding the PACE program and using those services as well. And so if that helps, that's a little bit of the landscape and discussion that the working groups have been having.
Thank you. Any other thoughts on the slide? And sorry, I'm going through pretty fast now because I do want to get to the summary slide. Go to the next one. It sounds like this is also an area where there must be pipeline issues.
It's the same issues here as what we've talked about with each. It's a significant issue, needs to be addressed holistically. There is definitive capacity issues in order to allow older adults to be able to stay at home. So I think there were more submissions in this the older adult kind of bucket or category. I think several of them went into the health classification, if that's helpful.
And so this gets into what Hina was just talking about in terms of thinking about the delivery model. Got it. Any other thoughts on this? Okay, next slide. And then once again, this is the same point we've been hearing around, the systems integration issue. So with that, that seems to be like another one of those areas like pipeline development that you may want to look at holistically across the health spectrum. So let's go to that last slide, and I'm going to be very curious to see where we came out. So here's where, and I haven't seen these. This is the OWL's working behind the scenes on this. So early areas of panel interest, basic needs around supportive housing, including residential settings, community-based resource and navigation, healthcare workforce pipeline development, and telehealth access, especially for rural Kansans. I think there was also something probably around the data integration side. Is this generally where people were hearing kind of the greatest areas of focus as we went through this? I realize we just went through like 200 areas. So. Let me flip it the other way. Is there anything missing?
I was just, as I looked at that slide, under community-based resources and navigation, I don't know if the issue I brought up a little while ago fits in there, and that has to do with facilities and expansion of facilities that need to be, so many of our organizations are in facilities that don't meet the needs. So I'll just say that again, we need facilities and we need staff.
Mm-hmm. Got it. Yeah, I think that's kind of a separate point from the community-based resources and navigation. It may butt up against it, but it's just understanding the kind of the situation across the facilities landscape. Thank you, Hina. Appreciate your time. Any other ones that, if we're just going to say kind of like the high point issues, and once again, a lot of these really span kind of the whole healthcare spectrum? Here's what we came out, as the team has been working in the back to start off with kind of all the potential areas in the parking lot and kind of what got moved up through kind of the discussion probably up into the working program areas. Why doesn't everyone take a look at this? And once again, some of these can probably be addressed in an integrated manner, like workforce pipeline development, but anything that's in the parking lot that people says, yeah, it really should go up to something we should continue to consider and flesh out, and then we'll eventually score, or things in the working program areas that don't make sense to folks.
John, just a quick timekeeping question. Are we going to go on for a little while or are we about to finish?
I think we're going to need to finish pretty soon, just
Okay, 'cause
because.
I have a 2:00 I need to jump off
Yeah.
for.
Well, we can ask folks, we can get this back out to folks and you can take a look at it and get us your comments. The other thing I'd say, well, appreciate everyone taking the time and the fact that this was super intense in terms of the amount of information that was, pushed at everyone. I appreciate all the experts. The other thing to keep in mind as we look at these areas, and what's in the working programs, to think about the ones in particular, that span, behavioral health, disability services, and senior services, because those might be some of the areas like, pipeline, where just because of the nature of how we're looking at it, we may be able to think about it a little differently and may be able to make some catalytic investments there. So just don't think about these in the context of the individual areas, but think about some things that may be issues to really focus in on that span kind of the healthcare spectrum. So with that, I'm going to kind of be cognizant of everyone's time. Really appreciate it. We'll get you this as a follow-up, and then we're going to follow up, as well, in anticipation of the next meeting. The next meeting on education will be way more focused in, and so we're probably going to get a chance to revisit some of these issues in that one as well. So with that, thank you.
Thank you for inviting us.